Welcome to Unrestrained, the podcast series from CPI. Here you can enjoy conversations where professionals on all sides of crisis and behavior management relax and open up about themselves, their workplace, and their clients. You'll get the latest tips and trends from the best in the business, so tune in often to integrate their experiences with your own. Hello and welcome to Unrestrained, the CPI podcast series. This is your host, Terry Vittone, and today I'm joined by Bob Durand. He is an emergency management planner and a practice leader working in the Medical Group Support Services Division of Kaiser Permanente's Northern California region, based in Oakland. Hello and welcome, Bob.
Hi, Terry. Thanks for having me.
You're welcome. And let me tell you a little more about our guest. Before transitioning to civilian life, Bob spent 21 years in the U.S. Army, where he assumed various leader positions, including Tier 1 Special Military Ops. After his military service, Bob transitioned into security and training roles in the healthcare field. In his role with the healthcare giant Kaiser Permanente, Bob is a regional asset for 21 separate facilities. He develops national strategy and conducts security officer training for postings within the emergency department, including management of the ED environment, patient management, physical intervention leadership, and staff protection. Bob was also instrumental in the introduction and training of the Workplace Violence Prevention Program at the Kaiser Permanente San Francisco Medical Center. Bob is certified as a healthcare environment manager and a HIPAA security specialist. But before I give too much away, let's jump into our questions. Bob, could you talk about your personal history a little more and how a desire to, quote, jump out of planes and kick indoors, as you told me in our pre-interview, led to your first role in emergency management?
No, thanks, Terry. So, when I was 12 years old, I want to do an adventurous job in my future. And that ultimately made me decide that I wanted to go into the U.S. Army, and I wanted to do a job that was challenging and fun and, and make it as tough as I could possibly make it, because I wanted that challenge. And one of the things that I learned in that time is that we have the ability to do anything we want, right? And through my 21 years of experience, it helped me understand that sometimes we can take one path or we can take another path that ultimately decides where we go and how we do things. And when I translate it into the subject of what CPI is all about and what we do to manage healthcare environment for safety, is that it's very simple to overcome a at-risk patient through brute force, but using appropriate principles that allow us to de-escalate before we ever get there is actually is much more valuable than just physically managing patients. And that history, that background of mine with the military is what ultimately helped me understand the value of de-escalation, the value of communication, and the value of interaction with our patients.
Is it because of the contrast between the military paradigm and the culture there and then going into safety and security and healthcare?
The funny thing about it is that there's so many things that are the same, right? Because, the military's healthcare system is a lot like the way Kaiser Permanente structures, right? And I guess at this point I should probably pause for a second and mention that, as I express my opinions, they're my opinions, and I don't necessarily speak on behalf of Kaiser Permanente.
Okay.
And, the thing being there, and when I go with this is that, the healthcare system in the military is one where you see your primary care, and your primary care is your point of contact for everything about keeping you healthy, which is the foundation of how Kaiser Permanente works. The idea being is that we do what we have to do to keep you healthy and keep you happy and keep you functioning is much more important than waiting until something is wrong to jump in and try to fix it. So, the overall strategies that are employed towards the healthcare system that is Kaiser Permanente is very much the same types of strategies that the military utilizes.
So, preventative measures take precedence.
Absolutely. There's that old saying that says an ounce of prevention is worth a pound of cure, and it works in every single arena when we talk about this, to include managing aggression.
Right. So you come out of your 21 years of service, and where do you land first?
Well, so the really interesting thing about that is my very last job in the military was healthcare recruiting. Looking after and trying to find any one of the 120 allied health specialties that are out there. And during that time, I bumped into some pharmaceutical reps, and they led me to believe that, being a pharmaceutical rep was the end-all, be-all in jobs. So when I left, I went into that, and I quickly realized that that's not what I wanted to do. There was not a service component to it. There wasn't a help your fellow man component, and which is entirely about who I am, right? That's what led to my 21 years of service. It's ultimately led me to where I am today within Kaiser. And, I got in that role, and I realized that it was about sales, and I wanted to do something more. So I left that job, and I went into healthcare security. And when I started, in my very first interview with the contract company that provides security for the hospital I worked at, because of my background, because of my education, because of all the things that I came to the table with, I was offered a manager's job. And I said, it's thank you. I appreciate that, but that's not going to help because I don't understand the way this works. So I need to function at the lowest level first. I need to be an officer first, and I need to work my way up from there. And I did that job for a year, and then I transitioned as a supervisor, and then I ultimately became a manager for a security program at a hospital. And through each one of those steps, I truly understood what it took to provide a safe, nurturing, caring environment within a healthcare system. And, interestingly enough, when we think about security, we often think about loss prevention. We all, often think about access control and, not letting people get to where, something is protected, right?
Mm-hmm.
And in the healthcare environment, you can't do that because we have to have an open, nurturing, caring environment by nature. We want our members and our patients to come for us for help. If we close ourselves off, if we make ourselves secure, as a hard target, then we are counterproductive to that. So the focus within healthcare security is such a different concept. Yes, there are times where you have to have certain areas totally secured, but for the most part, we want our members and our patients to understand that this is a safe haven. And it was through that practice that ultimately led to the next level of my career, which is where I am now.
Nice. What a balancing act to sort of pull off. It's interesting that you chose to work in security. You said, look, I'm not ready for the manager role yet. I need to understand this environment better before I step into that. It's very disciplined.
Thank you. And it was a hard lesson learned when I was in the Army. I actually had a job where I was moved into a leadership role for a function that I had never once worked in before. And, if you were to talk to my boss at the time, he would tell you I did okay. If you ask me, I failed miserably. And I realized that, in order to effectively lead, in order to effectively help others understand what they need to do, you have to be a subject matter expert. You have to be able to, and we throw this term around quite a bit, and that's lead from the front, right? You hear that quite a bit in corporate America, and there's a lot of times where that's misunderstood. What it truly means is helping your people understand, helping them learn, and providing them the tools to be successful, right? And so if you don't understand the material yourself, if you haven't fully embraced what those concepts are, you can't effectively do that. And jumping right into a leadership role with no fundamental understanding is actually very counterproductive to that.
Well, that transitions into my next question about, so now you've become this SME through your experience, and you go on to become at Kaiser Permanente San Francisco Medical Center. I believe you were involved in training there, and that you had some remarkable results as well.
That's correct. So within my role as emergency management planner for San Francisco Kaiser Permanente, part of my function was the AB 508 compliance program, which that particular regulation within California requires that people who work in an emergency department are trained on 11 items, as it applies to their security management plan. And I managed that program, and it's an annual requirement to do this training. And through that training program, we were able to virtually eliminate injuries within our emergency department from violent and unpredictable patients. And we are now into our fourth workplace safety year with no lost time from injuries. And that's a significant achievement when you think about the emergency department environment that we face. We have more angry patients. We have more unpredictable patients. We have more patients who are altered because of alcohol or drugs than we had, 5 years ago or 10 years ago. And the environment is just becoming more and more unpredictable. But the ultimate thing that in fact, it's funny, I was talking with one particular clinician last week, and he said, the biggest thing about this training isn't that I learned any one specific concept or any one specific measure or any one specific physical action to protect myself. It's that I gained confidence to work in the environment. And he said one of the biggest things that has led to our safety results is that our team is more confident. So when something happens...
Interrupt you just for 1 second. You're speaking in regard to verbal de-escalation techniques and, say, the crisis development model?
I'm referring to it all. I'm referring to, the de-escalation techniques. I'm, talking about how do we respond during the defensive phase when somebody is verbally aggressive or they're shutting down and shutting off contact. How do we manage when someone is now at risk and they're now beginning to physically act out? Every phase within the crisis development model, the staff is just more confident. And when someone calls out for help, instead of saying, looking around the corner and saying, what's going on, everybody now goes to the environment, and then they're able to function as a team to either de-escalate, regain control, whatever the requirement is to keep everybody safe. They're able to do that better. And he mentioned to me that it really truly is a team-building event, the training that is.
And I see here that you, between 2013 to the present at San Francisco Medical Center, following Permanente training and the ongoing training, you guys had 0 workplace injuries from violent and unpredictable patients.
Correct. And I will caveat this, that there were 2 incidents where a patient spit on a staff member, and then during a restraint, one staff member was scratched. But neither one of those resulted in lost time, and the staff members were not injured. But because we do hold ourselves accountable to every possible injury, we do count those.
Okay, so at what point did you come into San Francisco Med and think, I want to bring some de-escalation, some CPI training, some nonviolent crisis intervention into this environment?
So there's actually 2 reasons, right? One is the most simplistic and economical, and that is we use it across the board. So it was the standard training model that we're already using. Second is that in my opinion, once again, this is my opinion, when it comes to the de-escalation material, CPI offers the best program out there. And what I mean by that is the vocabulary you've chosen to use, the method in which you teach it, and the fundamentals behind it in terms of how you work through the crisis model and how you work through the verbal escalation continuum allows the end user, and that is the staff member, to fully understand what the risks are and what the options are for mitigating that risk. So when we talk about someone who is, experiencing anxiety, and we talk about those things that can actually help them not reach that next level, right? And more importantly, things that we can do to not perpetuate it ourselves. Because when I tell people in our training that when somebody is showing signs of anxiety, right, if all of a sudden we become directive, the patient isn't the one that's escalating. We are escalating the situation.
There's the integrated experience in going in.
Exactly, exactly, and that's the thing, right? And so often in the emergency department, when somebody is becoming anxious and they're becoming agitated and they're becoming aggressive, the automatic response is to just become to equal that energy, right?
Right.
That's what clinicians in the ED environment are taught from day one in terms of managing, and that approach doesn't always work. So when we look at the training, how training offers them choices in how they respond, is really truly what allows us to have less instances where there's a potential for injury.
See, around what time frame did CPI training started in San Francisco Med Center?
Oh, shoot. It was there before I got there, but that was only for the security department. When I moved into the role that I ultimately took up, the compliance training to cover the 11 items that the law requires was done utilizing a different concept. When I looked at what do we have, what can we do, and where can we go, that's when we introduced the CPI model into the training.
I see. And that would be roughly...
The very beginning of it was late 2012, early 2013.
Wow! So maybe part of your zero workplace injury results was that expansion of training.
Correct.
That's excellent. And how did you convince administration to grant you training budget?
Well, I'm going to tell you, it was tough, right? Because training healthcare workers is expensive.
Right.
By nature, their time. In any program, it doesn't matter what work segment you're in, what profession you're in, what industry you're in. The most expensive piece of any training program is the time, right? And so the actual program you select, the cost of that is negligible, right? It's very minimal, right, compared to the cost of the employee's time. And so we had to look at what can we do and what's it going to cost us. And more importantly, what is it going to do for us? And so the first year that we did the training, we did it with unbudgeted funds, which was really tough. And I will tell you that once leadership saw the benefit, it became automatically we budgeted in. We've already budgeted in the amount for training for 2017. And when you forecast that, you're able to absorb it easy. The big thing that I would tell anybody who's looking at doing it is you need to lay out up front what it's going to cost the organization, but why it's important for them to spend that money.
I see. And what are the positive outcomes of the training that would then say now you're automatically included in the budget? When you started, you were unbudgeted. What outcomes does administration look at and say we have to do this?
Well, so the biggest thing is we're not paying for lost time, right? That's when you look at the bare bones accounting, we're not paying because a staff member got hurt, and that's a huge difference, right? We're also safer with our patients. Now that's an intangible that you can't just look out and say, okay, because we didn't have to restrain this particular patient or there wasn't a risk of this patient getting hurt, that it saved us money. I don't think there's ever going to be a way for us to accurately quantify that.
Right.
But just making the environment safer saves money.
Well, yeah. When you can point to zero workplace injuries from violent and unpredictable patients at the San Francisco Med Center ED from 2013 to now, that's certainly a metric that stands out. That one would point to as a very desirable outcome so far as lost time. And just for the overall environment, the staff has got to feel more confident and secure in fulfilling their role.
That is correct.
Now, in our pre-interview, you talked about a training philosophy that you shared with trainees, and I really like this phrase, more sweat, less blood. Could you talk about that for me, Bob? So
one of the things that I see quite often, and this is not just healthcare, it's across the board in training, right? And that is we can our training because we're trying to package it, right? We're trying to create the least amount of impact on our employees. We want to make it easy for them to attend. We want them to make it easy for them to go through the learning process. And I am absolutely opposed to that, right? Now, I want to make it easy in terms of them scheduling it. I want to make it available to them, right? I want to make it so that they don't have a problem getting to a class. But once in a class, I want to challenge them. So when we talk about doing scenarios for verbal de-escalation, right? When you make somebody uncomfortable like they would be in a real situation, they can learn from it and they can grow, right? When we talk about going through the physical defensive techniques or the techniques that are used to regain control of somebody who's out of control, when we make those as realistic as we possibly can, we help the person learn how they truly can defend themselves, right? How they can truly make the environment safer by quickly and efficiently regaining control of somebody who's out of control. And ultimately, the one thing that I've preached from day one in my security experience is when someone gets to the point where they are now a physical threat to anybody, the longer they are in that status, the greater the risk of injury. So once we make the decision where we've got to regain control of somebody physically, we've got to do it quickly, efficiently, and as a team. Because if we don't do that, someone can get hurt. Additionally, there's not really an option to fail, right? You have to be successful or someone gets hurt, right? So in doing all of the training, the harder that you can make it on someone, the more challenging that you can make it on someone, right? The more involved you get them in that training, when they walk out of that classroom, they're going to be more confident, right? When they're faced with a similar situation in their environment, and I use ED because that's where I focus my stuff, is that when they get into that environment and they're dealing with somebody who's unpredictable or violent, they're better able to keep themselves safe because they've already experienced it.
Right. So, in other words, that simulation, making it all as close to and as tense and as adrenaline fueled as an actual encounter in the ED might be, really buys down that reaction once they actually experience it in real action.
That is absolutely correct, and that actually helped me. When I was looking at developing our program, I actually went back to CPI and I said, "What do you have that can help me?" And that's where I then attended applied physicals, and that helped me fully understand how to teach that material to the best of my capability.
I see. So you went after that, the advanced course. You sought that out.
Correct.
Excellent. And how many did you bring that into your training for? Portion of your staff, or was it an optional thing?
No,
How did you blend it in?
No. So what we did is we made the choice for our 2015 certification. We taught that material.
I see.
Right. So what we did is we offered all the de-escalation material. As like we discussed it during like staff huddles and all those things. We brought it up and we allowed them to kind of work that through that way. But when they came into the classroom, we focused on that. That was the material we taught in the classroom that particular year.
I see. So the physicals were the emphasis for that.
Correct.
I see. I'm wondering, Bob, how SB 1299 impacts your strategies. I mean, do you see you training as what does this legislative mandate do? Does a one-size-fits-all kind of that's almost a pejorative phrase, but do you customize by high, low, or medium?
Right. So a couple things to reiterate before I go into my opinions on this, and that is one thing is very we are still working it through. We with Kaiser Permanente, we still do not have our training plan solidified, and the reason being is that we're trying to make sure that we do two things. Right? And that is, one, meet the requirements of the regulations, right? But more importantly, we're trying to figure out a way to make sure that even those that don't fall under the regulation are still protected by what's the intent of this law, right?
I see.
Over the last several months, certain areas were taken out of scope of the law. And the big thing for us about that is that workplace violence is a trend everywhere now. It's not just in one specific area of any one specific organization. And we don't want to leave our areas that are out of scope unprotected.
Right.
So we're still trying to work through exactly how we're going to deliver the best training we can to the widest area. Okay. That's the first piece. The second piece is, I want to reiterate again, this is what I'm about to mention with you is my opinion. And so first off, different areas absolutely have different risks. I will tell you that and I'll use a couple different clinics that are synonymous with any healthcare organization, right? An audiology group, right, is a very low risk area, right? The people who are there are there for a very specific reason. Right. They're generally not anxious or agitated when they're seeking care. They're generally not altered when they're seeking care, and the risk is low, right? So training for them is not necessarily doesn't necessarily need to be the same as training for an emergency department, right? And emergency departments and healthcare facilities are some of the highest risk groups because of the nature of the patient population and the nature of families who accompany people to the emergency department, right? Because, by nature, people in emergency departments are stressed, right? In some cases, they're altered. In many cases, they're agitated out of fear or some other issue, right? I think about, when you look at the person who arrives at the emergency department agitated and altered because of their own, whatever they've done with themselves, that's one population, that's one risk. But a family member who arrives with their loved one having a heart attack is anxious. They are stressed. They are on edge. They need every bit the same care that their loved one probably needs, right? It's a different form of care, but they still need it, right? So by nature, emergency departments are higher risk, right? And so everything falls within that spectrum of the emergency department and that audiology clinic, right? And determining what training you offer to different areas really will make the difference of how you, budget your time, right? You allocate your resources, and most importantly, offer the most effective training to the correct group.
Speaking of the correct groups, I've heard, we've talked in your previous that it's your sense that all physicians should participate in de-escalation training. We like that thought, certainly. Could you tell our listeners what leads you to that conviction?
So the biggest reason why I believe this is physicians are the frontline care, right? So just like nurses, just like technicians, just like a number of other parts of the care continuum, they often put themselves in close contact, one-on-one, in closed rooms with someone who might be aggressive or agitated, right? Sense. And so by the nature of their work, especially when we talk about privacy, right, and we're talking about making sure that we are offering the patient everything that they are afforded, right, which includes privacy, physicians often put themselves in situations where they are in closed rooms, doors closed, they are private with their patients, as they should be, right? Yes. That leaves them exceptionally vulnerable. And a lot of times, when the patient is agitated, when they are anxious, when they are aggressive, the physician is the target of those.
And so it makes sense then for them to have a full skill set of de-escalation techniques that are readily at hand and practiced when they are in this situation.
And additionally, a lot of the tools that they learn during this, helps them word when they go to set limits, right? Because physicians are increasingly being put in positions where they have to set limits with patients.
Give me an example.
And, in the emergency department now, we have an epidemic in the United States, right? And that is we have people who are increasingly drug-seeking. And often the physician in the emergency department is the one that has to tell that patient no, right? And so the way that they do that, the way that they approach that, the way that they set those limits, when they are faced with those, really can determine an outcome in terms of managing somebody who might be significantly unpredictable.
Well, I mean, if they're seeking and say, because we read about the opioid epidemic, for instance, I mean, it used to be religion, they said, was the opiate of the masses. Now it seems that opiates are the opiates of the masses.
You are absolutely correct.
So you've got someone there jonesing, and the physician has to say, no, that's dangerous.
It is. It's absolutely dangerous, right? Because that patient is now unpredictable. That patient is a wild card. Their next action is totally unpredictable because most often they immediately become defensive, and they immediately become aggressive, and they immediately become a threat. And so how the physician manages that through limit setting, through a myriad of other tools that they can use, helps them maintain their own personal safety.
Wow, that I can see, especially with somebody who, as you say, is altered or seeking to get altered, that you would have to have some skill, some finesse, and some practice, indeed, at dealing with that sort of demand.
Correct.
I'm trying to put myself in this scenario and imagining how you would stay rational yourself when you knew that someone was desperate.
Exactly. And well, so one thing I will applaud many healthcare workers in the emergency department, and that is their job helps them learn that, right? Their job helps them learn to be rationally detached and allows them to objectively look at those situations, right? In some cases, that actually hinders because they are, more straightforward, they're more blunt, they're more direct, and in some cases that actually serves against them, right? By learning the techniques of limit setting, by learning, a myriad of other tools, they're able to use a different approach based on the situation.
Bob, now that you've become a regional asset for Kaiser Permanente and you manage 21 different facilities, how do you extrapolate that role that you had at San Francisco General and make it fit into all these different? I mean, they have to have differences, quite significant differences.
Oh, absolutely. So a couple things is that one is that my role as a practice leader allows me to offer tools, right? Because I don't have, I guess the word would be oversight, right? My role is more of I offer help, right? I offer solutions. I help them understand where they are and where they need to go and that sort of thing. And it allows me to objectively look at the programs and give them feedback as to where they are and where they can potentially go. So that's part of it. So the other piece is that, the locations of our medical centers and the things that they do, that each one of them do within their communities varies widely. And so there is no one-size-fits-all for them in terms of a practical solution or what we can do for them.
Give me a sense of what some of those facilities do or and how they differ.
Well, it literally is based on geography or based on the local climate of the counties in which they serve. And, some of the counties, I guess, for example, San Francisco, Kaiser, is not a dumping ground for law enforcement when they have someone who needs medical care, who is unpredictable, unstable, or is a risk, right? There's a county facility that accepts all those patients, right?
Right.
So while there's risk, it's not as high as some of the other facilities because we have other facilities where there aren't other choices, and that hospital is the one that gets that DUI who needs medical care, who's in police custody, or they get that patient who was recently 5150'd, which in California is the 72-hour psychiatric hold, who is, the police have instituted that order and they bring them to the hospital, right? So that does happen at some facilities who aren't the big receiving for those, but there's facilities where they are the only medical center in their community that accepts those. So those ones are the ones that are at higher risk. And that's the big difference.
And how would you say the training for these 21 centers, as far as de-escalation techniques or CPI training, is that in place in a large number of these?
Yes. And, we're working on expanding it, actually. We're looking at different ways we can deliver the material to more people. And, we're going to, part of our solution for SB 1299 is going to be widening out the scope of who gets the training.
I see. So you're going to, that's good news, that to train more people, like as part of your philosophy that you were speaking of earlier, that every facet, from audiology to the ED, deserves the same level of competence and training when it comes to de-escalation techniques.
Correct. So
any last thoughts today, Bob? Any talk about who inspired you professionally and what created that? I guess it's maybe hard to answer. What led you to such a service-driven orientation and desire to help people?
Well, so it's been throughout my life. I've had a number of, I've had some amazing military leaders who coached me through my time, right? I had some leaders who sat me down and said, this is what you can really do for the world, right? And so on. And then I've had some mentors in the healthcare world right? And the funniest thing, is that when I went into the healthcare world post-Army, I spoke Army. I spoke Department of Defense. I was a soldier, right? And I can tell you that, there were some times where my vocabulary wasn't the same as the vocabulary of healthcare. And so I had mentors who helped me learn how to communicate and how to teach with the most impact through utilizing terminology that was that's prevalent in the healthcare world, right? And I can tell you that when it comes to structuring a training program, you need to make sure that as a fundamental trainer, everything is geared to how well you deliver the material, right? How well you help. And I'm not real big on quotes because I often forget who said them, but I do remember there's one very specific one that sticks out at me, and it says, if you can't explain something to a 5-year-old, you don't fully understand it yourself. And so I try to make sure that when I'm teaching something, when I'm delivering something, when I'm orienting somebody to something, that first off, I understand it, because I can stand up and I can read a slide and I can say, you do this, do this, do this, but that doesn't help somebody learn, right? When you're trying to help someone learn the concepts, you need to make sure that you've taken time to fully understand the material yourself and then deliver it in a way that helps the end user, the person that's going to benefit from it, truly understand it.
Well said. All right, Bob. Well, today my guest has been Bob Durand. He is the Emergency Management Planner and Practice Leader for Kaiser Permanente's Northern California region. Bob, thank you so much for joining us today on Unrestrained.
And once again, thank you very much for having me.
All right. And thank you for listening. Thank you for joining us today on Unrestrained. Tune in again soon for another interview with an expert in behavior management. Until then, this is your host, Terry Vittone, hoping your intention is prevention.